Okay, everybody, I think we can go ahead and get started. Thank you to everybody who's here today for the Department of Medicine and Division of Pulmonary Critical Care Medicine Grand Rounds. Again, we're thankful to the Division of Pulmonary and Critical Care Medicine who really got this started. Now going back 6 weeks ago, and we've been continuing this every week with some fantastic speakers, and that continues today. We're lucky to have Sidra Raoof, who's one of our first-year pulmonary critical care fellows, who's going to be starting us off with a case. And then we'll be continuing with Dr. Bob Arnold, who's the chief of the section of Palliative Care and Medical Ethics at UPMC, University of Pittsburgh School of Medicine. And I do want to give a thank you to one of our hospitalists, Karthik Koda, who did his training at Pittsburgh. And when I reached out to him to ask him who he thought might be a wonderful speaker who could talk to us about goals of care in the era of COVID, he mentioned that Bob Arnold would not just be a wonderful mind to speak about it, but a fantastic speaker. So I'm really looking forward to this. And Dr. Arnold is going to make this an interactive session. So instead of doing it the way we have, where you submit comments or questions directly to me, we're going to have an open discussion the entire time. So make sure that you don't fall asleep. If you need an extra cup of coffee, go get it right now, because you never know, you might get called on. So thank you for everybody who's here. Thank you to Dr. Arnold. And Sidra, why don't you go ahead and get us started with the case?
Okay. Okay, I'm trying to share my screen. Okay, is it working?
Yeah.
Okay, all right. Good afternoon, everyone. My name is Sidra. I'm one of the PGY4 fellows. So we'll be talking about goals of care, as Dr. Cohen was mentioning. Let me see if I can move to the next slide. Okay, so the outline for the presentation would be, I'll go over the learning objectives, I'll present a case. Since we are making this interactive, so we can take questions while I'm presenting the case and then discuss as we are going on. And then we can continue our discussion after the case, and then we'll have some like take home points for everyone. Just to give an overview, the learning objectives would be for us to understand the importance of having the goals of care discussion, especially in the COVID era. We will talk about the emotions that are like involved in having difficult conversation, and how do you like respond to these strong emotions. What are the things that you can use? Certain questions that can help you see what patient, where the patient is coming from, what their values are. And then also as nowadays with COVID-19, there's a lot of barrier in how we are having this conversation. So we will be touching some light on that too. So this case is basically of a 64 years old female that was brought in by EMS for shortness of breath. She was very like hypoxic at home, so had to be placed on a non-rebreather, was brought to the ED in respiratory distress. So I was one of the fellows who was covering the night float, and they called us for admission, mainly for seeing if patient probably has an impending respiratory failure. And when they told me the name, I had actually seen this patient like 2 months ago. I was involved in her hospitalization briefly, but she was in ICU. So I knew her from before. So when I came to see the patient, she obviously was not breathing good. She was breathing very fast, was hypoxic. Her vitals were unstable. She was tachycardic. As we can see, the heart rate was in the 120s to 140s. Blood pressures were unstable too. But when I saw her, like she, compared to when I last saw her 2 months ago, she was very cachectic, and then looked like a totally different person. looked very old compared to her like stated age of 64. So then some of her past medical. So she was fairly healthy up until like November of 2019 when she was like diagnosed with CLL. She had a bone marrow transplant and then had a lot of problems right after. So she had a low EF, she had pancytopenia, she was dependent on transfusion, developed resistant HSV infection, had pulmonary nocardia in January, had a bronch then, had C. diff, graft versus host disease, had bacteremia. And then last time when she was in the hospital, she had a rhinovirus, a metapneumovirus, pneumonia, along with HSV pneumonia. So this was her 4th hospital admission since like November, December of 2019. The last admission was in April. And as I mentioned, at that time, she was in the hospital for like 1.5 months. She got intubated during that stay, was in ICU, was diagnosed with HSV, RSV, and metapneumovirus pneumonia, was also had some like organizing pneumonia later on, so was on steroids. After she was sent home, she was still getting like IV hydration. She was going to the clinic for getting IVIG and then platelet transfusion and colony stimulating factors. So during one of her clinic visits, she was seen that she was more hypoxic, and there was concern that it might be like graft versus host disease. So the plan was to actually start her on azithromycin. She subsequently developed fevers, was in distress, and then that is how she ended up being in the ED. Her husband and daughter tested positive while she was living with them. She tested negative like repeatedly. So just an overview of her medication. So I have like over 20 medications that are listed here that this patient was getting. She was basically immunosuppressed. She was getting prednisone and then a lot of other prophylactic medications that we can see here. This is her initial blood work. So we can see that she was pancytopenic with a low white count, hemoglobin, and platelet count. And also, this was her CAT scan on arrival, which was done in the ED. This is just one snippet from there. So some of this was old, like she has some like reticular areas, but then she had a new consolidation on the right side in the lower lobes. And then we were thinking this is the reason that she is now more hypoxic. So looking at all of this, obviously the next stage was to, have a discussion with the patient and let her know like what's going on. And so because I had known this patient before, she was someone who was very anxious at baseline. She had the prior intubations that she had some like PTSD from that. So while I was there and I told her, like I asked her how's her breathing, she initially wouldn't, because she was afraid that, she is also getting tired, she wouldn't give me the true answer. But then she was initially said that she would not want to be intubated and then like try other things first. And then also because she was COVID, she did not have family at bedside. So then I tried to arrange a call with her family. So the husband and the son were the ones who were involved in her care. So in the meantime, we put her on like non-invasive ventilation till, she said she needs time to think about like intubation, and then she wants to talk to her family. So we did all of that, and then she got a chance to talk to the family over the phone. The husband and the son wanted everything done. Right before, like then she finally, obviously she started tiring out, and then she agreed that she would, that she's okay with intubation. Before, like right around that time, she, because she had no family around, so like it was like she was very worried, and she asked me this question, and like obviously looking at her comorbidities and looking at her previous few months, any doctor can say that she obviously is very less likely to have a good outcome. But then she asked me this question. She was holding my hand and she said, am I going to die? And then she said, please don't let me die. So she, like, at that point, like, what I told her was, you know, we'll try, you know, we are trying to make you better, and we'll give you everything, and let's hope, you know, that you recover from this. But then at that point, I felt like maybe her family being at bedside would have been ideal, because then they would have been able to, you know, talk to her. She would have been able to see them in person. So she got intubated. This is her x-ray after intubation. And then we can see the same thing, that she has the right lower lobe pneumonia. These are her initial blood gas. The ABG was 7.05, PCO2 was 64, and PO2 was 96. CRP was high, her pro-BNP was high, troponin was high, LDH was high. So she stayed in the hospital for like over a week. And during her hospital course, she developed, she had an MSSA pneumonia and had an MSSA bacteremia. Also ended up having a pneumomediastinum and pneumothorax, which needed like chest tube, which was put in and then removed. Also had ischemic ATN and then hypernatremia during that hospital stay. So then roughly around 11th night of admission, I was on nights. So the nursing called because they were concerned that she was getting more hypoxic on the ventilator. So we walk into the room, and then obviously we find her that she is hypoxic, but she's also hypotensive and very uncomfortable. So then we did the medical stuff, like sedated her more, ordered a chest x-ray, but all of this is like medical talk. What I also, you know, when you walk in, what I observed was that she had, like, she was hooked onto a ventilator. She looked like she was in pain. And then because she developed this extensive subcutaneous emphysema, she had like extensive swelling, had like weeping ulcers. And I wasn't able to recognize her from the day when I admitted her. And this is her x-ray from that night. So you can see there's extensive like subcutaneous emphysema. The reason that she was hypoxic on top of everything else that was going on, the reason that she was more acutely hypoxic was that she had a pneumothorax on the right. And we can see that there's a chest tube there that I had to put in, but I called the husband and we had like a long discussion. And as I was telling the husband, you know, that she is not doing good and she's not, you know, making the progress as we would expect her to, what he was concerned about was, you know, absolute numbers. So he was kept on asking me that what's the white cell count? The white cell count is going up or down. Did we change the antibiotics? What's her FiO2? So all the technical terms, but he was in denial and was not ready to accept that she was, you know, in fact, not going to make out of this hospitalization. He still wanted me to go ahead and put in the chest tube. And so we did. But like in the morning, the team, like we got like a CT head, and it was seen that she had some skeletal metastases. Going back at her, looking at her echo, she also had what seemed to be like pericardial metastases. So in the morning, like after extensive goals of care discussion, which had been going on ever since her admission, the family finally decided to make her comfort care, and then she passed away. So this was my last slide, but are there any questions that anybody wants to ask right now?
Okay, thank you, Sidra. So Dr. Arnold, if you want to give us some of your perspective and your thoughts.
Yeah, can you stop sharing so I can share mine?
Yes.
Thank you so much. Perfect.
Yeah, if anybody has any questions then you can go ahead and type it in the chat.
So hi, I'm Bob Arnold. I'm from the University of Pittsburgh. A lot of my slides come from a group that I and James Tulsky and Tony Bach work with called Vital Talk. You may not recognize me because the picture before was pre-COVID. This is my post-COVID hair, which I apologize for. I think that was a really fascinating story because this is the story that we hear all the time. And what do we say? He just doesn't get it. He's in denial. Their expectations are off the wall. Don't they see what's happening? I mean, oh my God, she just doesn't, from 4 months ago, she's dying. Where are they getting their information? The challenge has been that for this lady, we've been trying to extend lifespan. She's had a bone marrow transplant. Everyone says we need to do more. It's just a problem that we need to fix it. End of disease-oriented treatment is viewed as failure. And we're invested in not failing, and the family's invested in not failing. Can you imagine saying for your wife or your mom, don't do everything? Ooh, what kind of husband are you that you don't want to do everything for your wife? We're invested in our expertise, which is biologic, and hope is often based on the next treatment. So you end up like this menu where you say, what do you want? What do you want? You get to choose. We don't think it may not work, but you choose. In the end, it's your decision. I want to give you a different way to think about these issues. It's called Remap, where first you have to explain that the status quo isn't working. Second, you should expect emotion. Third, you need to step back from any decision to map what's important. Show them that you heard what's important and align, and then suggest a plan. When do you talk about goals of care with a patient or a family? Let's be honest, we only talk about it when things aren't going well. So the patient and family need to understand that the reason we're talking about goals of care is that the old plan doesn't work. So the first part of any goals of care conversation is a serious news conversation. And that involves asking, telling, and then asking. What have you heard about how things are going with your son's cancer? I would have said to this woman, what have your doctors been telling you about how your disease is going? I would have said to the husband, what have people told you since she was in the hospital yesterday? Now, I say, what have you heard or what have people told you, rather than what do you know? Because I don't want to make them feel like this is about their knowledge. I want them just to report what other people have told them. I also say, what does the internet say? Because I can promise you that they're Googling what's wrong, and I want to know what they're reading, because if I don't respond to it, they say, Dr. Arnold, he's not even as smart as Google. He doesn't know about those Chinese stem cell transplants or that drug that the president is talking about. If I know what people know, then I can respond to it more successfully. And then I say, would it be okay if I tell you what I know? Because I want them to attend to me. I think in the era of COVID, I say every time, would you like me to get your loved one on the phone so they can listen while I'm having this conversation? I also love this new app called Abridge that allows them to audio tape my conversation, transcribe it, and then I can send it to patients. So I really love being able to do that, because I don't love having an hour-long conversation with the patient and then having the patient say, can you call my husband and tell him what you said? It's like, I just spent an hour. So after I ask, I have to tell the news, which means I have to give a headline and then I have to stop. Now, what's a headline? For those of you who are young, think of a tweet. It's one or two sentences that give the take-home message. It's what they would tell their family when they call home after talking to me. Two sentences. One sentence, what's the matter? The second sentence is, what does it mean? It's got to be in 4th or 5th grade language, because most Americans, that's their reading level. 50% of Americans don't know what metastases mean. If I'm unsure what's going to happen, I'll say, well, I hope your lungs will get better. I worry that you're not going to be able to breathe on your own. Or I worry, whatever it means. Okay, so this is why you all are on the chat. I'm going to give you a case. I'm going to make you write down the headline. This case is pretty close to the case that got presented. Mrs. Jones is an 83-year-old woman who's admitted from a long-care hospital with an aspiration pneumonia. She's intubated with severe hypoxia and an altered mental status. She's got a blood pressure, a mean arterial pressure of about 70 to 80 on 2 pressors. She's got ARDS with an FiO2 of 0.8. Her creatinine is now 5, and she's really not having much urine output. She's had 2 episodes of rapid AFib. You're calling her husband to give him the headline. When you asked him what he knew, he said, well, they said she was sick, but the nurse this morning said she was stable. You said, can I share with you what I know? The husband said, yes. I'm going to give you 30 seconds. I want you to write, don't send it, write your headline in the chat, and then I'm going to ask everybody to send it at once. So 30 seconds, write your headline. Hung, don't be sending it till I say send it. Okay, 3, 2, 1, send. So I just want to note there is a wide variation from she's severely ill with pneumonia to severe complications and multisystem organ failure, a lot of multisystem organ failure. I would tell you that families don't understand what that means. To a couple of people using the words dying, my headline to the husband would be, despite all the things we're doing for your wife's pneumonia, I'm worried that she's dying. I think that I wouldn't say she's very sick. He knows she's very sick. She's in the ICU. It's really important to write a headline for a 5th grader, which means 2 sentences. 1, what's happening? 2nd, what does it mean? For any of you who have talked to families and you think you gave a headline and the family says, what does it mean? What it means is that you didn't really give a good headline. When I call this husband up, when she has a pneumothorax, my headline is going to be, I'm worried that she's dying. I want to tell you that it's hard to give a headline, that I tell interns and fellows to write down your headline before you call the family up or go in the room. Because if you don't write it down, you won't say it clearly. You will hedge. Now, remember, I told you that the ask, tell, ask. The second ask, and this is when I'm just giving bad news, is to ask about what questions and to ask them to do a teach back, to tell me what they heard. In this conversation, I gave a headline. I told him, I was worried your wife is dying. How will I know that he heard? What will I see? What will you see if I say, despite all the things we're doing for her pneumonia, we are worried she is dying? How will you know that he heard you? Anybody, type in the chat. How will you know that the husband heard you? He starts crying. He'll be upset. He'll cry. He'll be angry. Let me just tell you that if you get an emotional reaction, that's not bad. That means that they heard the reframe. Now, I need to talk to you about emotions. Emotions work faster than cognition. There are good evolutionary reasons for that. When you see a lion, you don't do well if you sit and say, huh, that's a lion. I wonder what I should do. It works better from an evolutionary point of view if you get really scared and run. It's also the case that emotions overwhelm cognition. So in this lady, when she says, am I going to die? Please don't let me die. I don't hear that as a cognitive comment. I hear that as scaredness. And when people are scared, they don't listen very well. There's a great functional MRI study that showed that when you do functional MRIs and people who are emotional, their cerebral cortexes or temporal lobes go silent. They go metabolically silent because you don't hear very well. So some of you, I hope, are residents and are still awake. Let's say how many of the residents have had a bad day at work in the last 2 weeks? Anybody? Can someone respond to me saying that whether any of you have had a bad day at work in the last 2 weeks? Hell yes. Oh, I love David. Okay. So you come home, you're talking to your partner. What do you want your partner to say? Anybody, what do you want your partner to say? Emily, nothing. Oh, you don't trust your partner. Emily, what do you want your partner to say? You want them to listen. You want them to name or understand. You want them to say, oh my God, that sounds really tough. You want them to explore. That's what Emily said. You want them to say, oh my God, that attending is a dick. I can't believe he yelled at you. You're working as hard as you can, which is a respect comment. I can't imagine what you're going through with COVID in the hospital. An understanding comment. Oh, that sounds like it was really tough. A naming comment. That is, when you hear strong emotions, you want someone to respond to the emotion. You don't want them to give you facts. You don't want them to try to make it better. Here's an example.
Okay. You know, I don't understand.
The doctor has just told the patient that his prostate cancer has come back. Here's what the patient says.
I don't understand. That radiation doctor, when I had the seeds done, he assured me that the whole issue was now in the rear view mirror. Those were his words. They were in the rear view mirror.
And so now it's really sort of disappointing and maybe a little bit of a shock to hear the news. I'm suggesting that we have to actually look further.
Yeah.
He just named the emotion. He didn't try to fix it. He just said, yeah, I hear you. Now I'm going to tell you that's what we want you to do. And I'm going to tell you that you need to keep doing that until the family seems to have calmed down. They may calm down and say, so what are you going to do? Or you may think they're calmer and you say, can we talk about what comes next? This is the mapping part, the M. Rather than talk about the treatments, I want you to step back to talk about goals. So I view this, for those of you who watch basketball, what used to be basketball, as what Steph Curry does. Step back, get a little bit of space so then you can shoot. So say, can we step back and think about what you were hoping for? And that will help let us come up with the right choice for you. Or there are different options. To find the one that's right for your wife, I need to know a little bit more about your wife. So now you can remember, you're reframing, you're expecting emotion, and now you're mapping the future. This is what someone had asked in the chat before. I need to say, has your wife ever written a living will? Had he ever talked about if things go not the way you'd hoped? Have you ever had to deal with any issues like this in your family? These are mapping questions about the past. Here are mapping questions about the present. Given what I've told you, if your dad was sitting here, what would he say is most important? Given what I've told you, what would concern your dad the most? What would she say she wanted to avoid if she knew she wasn't going to be able to get back to the way she was? Or if the doctors were worried her time was short? What would your dad think if he was sitting here and could hear what we are saying? You may notice that I don't say, what do you want me to do? I don't use the word want. Let me ask you, Dr. Cohen, where do you want to be right now? You have to type your answer. Outside. In New Jersey, or if you could be anywhere, where would you want to be right now? On a beach. Yeah, they're all closed. Don't worry about that. The problem with the word want is a fantasy word all by yourself. Want is a fantasy word. So the question that I love is, what would your dad think if he was sitting here and could hear what we are saying? Some people are like, I have no idea. We've never talked about it. And then I try to figure out what experientially are mapping questions. Or tell me about your husband. What was his life these past few months? What kinds of things did he do that brought him joy? Often the first question, your first answer to these questions is live longer. That's okay. Say, what else? What other things would your wife be hoping for? What would she be hoping for if living longer was unlikely? That is, I want you to get a deep sense of what the patient's values are. You may need to probe for balance. It sounds like being at home is important, and yet you want to live as long as possible. Can you help me think about which your dad would think is a higher priority? I map and I ask at least 2 or 3 mapping questions to try to put people in 3 buckets. One is comfort measures only. Their life has been miserable. They wouldn't want to be like this. 2 is it's okay if I can get them some quality of life and they wouldn't want to go past this. And then there are 10 to 20% of people who are vitalists, whose view is any life is worthwhile, quality doesn't matter. I also want to attend when you talk to surrogates about family identity. Listen, for example, when I give this talk to parents who are, older parents who are, their kids are sick, what we know from the pediatric world is that what often makes these decisions is people want to be a good husband or a good son or a good wife. And how they define what that means often leads them to make their decisions. You need to praise them for their efforts because they want to do right by their spouse. I want you to watch this conversation. And then I'm going to ask you in the chat as you watch it, write some things down that you like that this doctor did.
Can we talk about next steps?
So I don't want to pull the plug.
If your mother was here and could hear what I've said about her condition, what would she say?
I hadn't thought about it like that. But knowing my mom, she'd say, I don't like this at all. It's not worth it.
What did that doctor do that you liked? Can people type for me? Allowed silence. What else? Paused. Didn't stop after the family member gave an answer. Asked an open-ended question. So I often have family members say, I want you to do everything for my wife. And I say, of course you do. You're a good husband. If your wife was sitting here, what would your wife say if she could hear what we've been saying? She's a fighter. I hear you. What would be worth fighting for? Tell me about the quality of life that she would say this is worth going through. Now, I do want to acknowledge that there are some people who can't think about their loved one dying, and they can't think about dying. And the question that I often ask is, I wonder if we can talk about or think about what your wife would say if she got sicker. And if they say, I can't think about that, that's their way of telling you that they aren't going to have this discussion. And then I just acknowledge the emotion. I hear you. It's just too scary. Now, aligning in Remap, remember I've mapped, aligning just once, all you're doing is doing a summary statement. As I listen, it sounds like this is what is important. This is what you want to avoid. That is, it's just your way of making sure that you've heard what the family says. And then I say, can I make a suggestion about what we should do next? That is, I don't say you get to choose. I will ask for their agreement, and yet I will make a suggestion. If I go to a good restaurant, those are these places where someone else cooks the food. You may remember them. If I go to an expensive restaurant and I say to the waiter, if you're only going to eat here once, what's good? And they say everything is good, it's a really bad waiter. A good waiter will say, ooh, do you like fish or meat? And then after they map my values, they will say, well, here's what I would suggest. When you make your suggestions, start by telling them the things that you can do, and then say, given what you've told me, here's what we shouldn't do. And if you're not sure, you can say, I'm not sure, given what you've said, whether we should do this. Can we talk a little bit more about the positives and negatives? Does that make sense? I am not asking that they feel like they made the decision. I am asking that they assent to the plan that I gave them. A plan that is based on their loved one's values. So here's the map. Reframe, expect emotion, map what's important, align with values, and make a plan. I'll often say, in this lady, I would say, unless she's a vitalist, I would say, given what you said about your wife, that she wants to live as long as possible, as long as I think she has a chance to go home, I think that if she gets a lot worse and her heart stops, I think doing that CPR stuff you see on television, I don't think we should do that. Now, COVID brings unique issues. We've talked a lot about trauma and fear and uncertainty. Virtual communication is really hard. If having these conversations in person is a 101 skill, doing them virtually is a 201 skill. And I would say you're having interns come in 2 months, it's not an intern skill. It's a second or third year resident or fellow skill. Do not send your interns to do this. It would be like letting an intern run a code by themselves. So it's really important that you think about how can you use technology, Zoom, FaceTime, whatever your hospital says, so that you can bring them into the room as much as possible. We have tried at VitalTalk to put together a communication playbook at vitaltalk.org where we have a lot of ready-made phrases for all of you that you can try. We also have an app which is free called VitalTalk Tips, and we put it all on the app. And we have some videos about how can you walk a family member through about how to say goodbye when they can't be there. So we wanted, one more thing. What if I give a plan and the family disagrees? I say, help me understand your thinking. That is, I don't try to convince them because maybe I heard them right. I just want to hear what they have to say and then try to understand if it's an emotion or if it's a cognitive issue. Okay, we wanted to leave 15 minutes because I have no idea what your lives are like to let you ask questions. So please ask questions.
Sidra, there was a question in the beginning, a couple questions about whether goals of care were discussed in previous admissions with the patient.
So as far as I can tell, I didn't see any palliative care consult or a palliative care note. I'm not sure if that was done by whoever the physician was, but I didn't see any good documentation if that was done earlier.
So I'm going to point out to you all that if you're waiting for palliative care, we're all going to be screwed. This is a competency of all oncologists and hospitalists and ICU doctors and people who take care of people with chronic kidney disease. And we should have known, given her last hospitalization, that she had a pretty high risk of dying. And so I'm going to say, looking back, if we were going to do a mortality review, I'd be like, oh, what happened? I love palliative care. I'm a palliative care doctor, and yet we can't sort of say only palliative care doctors have these conversations. What other questions?
There's a question on here about hypoxic patients being able to speak for themselves.
Sometimes they can and sometimes they can't. I look at it as, when I ask them, what have people told you is going on? Are they delirious? Now, I would tell all of you that medical doctors suck in screening for delirium. And so you all ought to know how to do a quick CAM to screen for delirium, because otherwise we get confused about whether people are going to be delirious. I don't say when you're hypoxic, I can see you're really short of breath. Do you want us to do something to help with that? Because again, I've used the word want and I focused on I can fix their problem. I don't think it's really a fixing problem issue. the question of when do I call palliative care, you're all at an academic institution. It's sort of like, when do I call the endocrinologist for advice on how to take care of blood sugars? Well, I think Dr. Cohen would say, if you call me before you've looked at the blood sugars and come up with a plan, he'll roll his eyes. If you call us to have a goals of care conversation and you haven't talked to the family, as an educator, I'm going to say, oh, come on, please. Call me after you've had a conversation and you're stuck. Call me to watch you have a conversation and educate you. Call me for your views. I think all those things are great reasons to call palliative care. And yet, again, it's like taking care of diabetes. You ought to have the initial skills. Someone asked about, what do you do when there are multiple doctors? I think it's really important when there are multiple doctors. It's why the headline is so important. Before you call the family, all of you need to sit down with all the doctors and you need to say together, what's the headline we want to give the family? Because the problem is, if you're trying to decide among 17 different headlines, it's really confusing. It's why Americans are having such trouble these days in politics. They're getting such different headlines from different sources. It's hard to know what the truth is. I think it is very difficult to coordinate. One of my favorite slides is, it shows a patient intubated in the ICU and it says, for want of a 30-minute meeting, we spent 2 weeks in the ICU. And so I'm not going to tell you that particularly you guys are stretched so thin that it's really hard to get people to coordinate meetings. And that's an operational issue. I think it's really hard. And you need to think about, can we train our nurses to set up the meetings and be present at the meetings? In our hospital, we have nurses who make sure that every 3 days in the ICU that there's a family meeting and they schedule it. So all I need to do is walk in and have us meet, and then we can have the family meeting, because the nurses own it, and it's an operational issue that they just keep this big whiteboard in their family meetings every 3 days. It's part of what we do in the ICU or on the floor with our really sick patients.
Dr. Arnold, there's a question about how much of a split comes from our quote medical versus quote surgical backgrounds. And there's the comment that this person's seen surgeons refuse futile procedures and treatments. And it makes me think of very early in the course of the pandemic, when there was more concerns about PPE and less known about the spread, that there was talk about chemical only codes, resuscitation for patients.
So I think that the question is, can we just say it's futile? And I guess the question I would ask in the case that got presented, when would we have said that it was futile? We are not that good at prognosticating that if you're in the ICU and you develop renal failure, you have a 70% mortality. It's not 100% mortality. And so I worry that when we say it's futile, what we mean is it's not worth going through that, given the quality of life they're likely to have on the other side. And I think that we should have a conversation about futility. In my experience, what's futile is how we have these conversations, way more than the decisions that get made. I'm not saying that it's not an issue. I am saying that we need to ask ourselves as clinicians, what can we do better about these conversations? I think that when we're uncertain, I'll often say, This is a really hard disease to be clear about what's going to happen. I'm hoping your dad will get better. And I'm worried that given the data, I'm worried that he may not. I think we're going to need to watch for the next 3 days. Here are the things we're watching for. I'm okay with expressing uncertainty. I need to give them some idea of what we're watching for. So if something happens, we'll come back and reapproach it. What other questions?
Question about how do we reconcile a new disease with its uncertainty and the uncertain prognosis that goes along with it, and how we frame goals of care in these conversations.
Again, I'm okay saying, you know, I wish I could tell you what the future is going to bring. Here's what my best opinion is about the best case and the worst case. I think in COVID, we don't know everything. We have a better idea about how things are going. Are other hospitals starting to allow visitors? Well, I don't know about all other hospitals. We are allowing one visitor to come in. They're being screened. They're doing all sorts of things, but we are a very low probability. We have nowhere near as much COVID as you do. We've also bought about 20 iPads, and all our palliative care services have iPads, and we've been using the heck out of iPads to have them communicate with families. So if you look at the Vital Talk page, we've given words that you can use when there is rationing occurring. There is no one in New York who said they did explicit rationing, but we stood up some language that you could use for two things. One is rationing, and the other is we stood up some very explicit language about how to talk about worries about discrimination. Because I think that given the press about how this has turned out to be a disease in which Blacks die much more frequently than whites, I wouldn't be surprised if people have said to you, well, are you doing this just because, or I don't trust this. Okay, so it's 12:57 and timeliness is next to godliness. So I'd like you to all take a minute. I'm gonna ask for feedback. I want you to tell me one thing that you are gonna try to do different based on this talk. So if you put that in the chat section, that will be very helpful for me. One thing that you will try in the next 2 weeks of being a doctor or a nurse practitioner or whatever you are, that you will try to do differently, having heard this talk. Thanks to the first two people. Great. A couple more people. Okay. Thank you so much. I am, Dr. Cohen, if you want, I'll send the slides to you without the videos because it makes it too big. And I wish you all luck and stay healthy and wash your hands. Thanks all.
Thank you very much.
And this is a lecture. If you want to get good at these skills, it requires your practice, and I'm more than glad to talk to anybody offline. I'll send you my email. Feel free to email me if you want to talk about how you can practice these skills offline. Thank you all.
Thank you very much.
Bye.